Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice.
My name is Dowell, physician assistant, working in orthopedic urgent care, again presenting another case study. I had a 41-year-old gentleman come into clinic. He was originally seen in the urgent care at an outpatient facility, diagnosed at that time with an ankle injury. He had significant increased pain with weight bearing, was placed in a walking boot, and then asked to follow up with orthopedics. He presented to the orthopedic urgent care for evaluation, stating that he still has quite a bit of pain, especially with ambulation in the walking boot, to the point where he had to go get crutches and use crutches to help him with ambulation assistance. He also complains that the boot seems to be rubbing on the outside aspect of his upper leg and causing quite a bit of pain and disruption within this area. When questioning the patient, he said he missed the last two steps walking down the stairs. Unfortunately, kind of landed awkwardly with a twisting sensation to the right ankle. He immediately had pain with weight bearing, and that's what presented to the emergency room. On examination, he had quite a bit of tenderness within his proximal fibular area to examination. He had tenderness diffusely throughout the anterior and posterior kind of syndesmotic area, and then quite a bit of tenderness over the medial deltoid ligament area. Ankle x-rays were obtained during the urgent care visit. These x-rays did not show any evidence of a fracture within the ankle area. Therefore, that's why he was diagnosed with a sprain and placed in the walking boot. Based upon his tenderness within the proximal fibular area, I did get some x-rays of his tib fib, and these did show a proximal fibular fracture. At that point, I was concerned about a Maisonneuve type fracture within the ankle area. We told him to remain strict non-weight bearing, continue in the walking boot that he was currently in. I sent him to see one of our foot and ankle specialists. Stress views were obtained, gravity stress views where they have the patient lie on the side, fibula down, and allow gravity to kind of pull, possibly open that syndesmotic area. These were positive for increased widening within the syndesmosis, and fixation was performed using a tightrope to fixate this area. He was told to remain non-weight bearing for 6 weeks afterwards, was able to continue to progress with physical therapy activities, and actually did quite well. I thought this was a good case of something that I see commonly in the orthopedic urgent care. These Maisonneuve fractures are probably one of the most common missed lower extremity fractures in the urgent care setting. I always like to start my physical exam whenever I'm doing any foot and ankle exams, palpating within this proximal fibular area. You know, we're all taught in school that it's important to palpate a joint above and a joint below. And I try to remember this when doing any examinations, whether it be upper or lower extremity, because oftentimes, obviously the ankle is quite swollen, edematous, with a lot of bit of ecchymosis diffusely throughout the ankle area. So we get focused on this area as the location of injury. But sometimes these types of things can be missed where we don't palpate a joint above or a joint below. And there could be soft tissue and or structural damage to these areas that can be missed and not picked up until the patient starts to try to weight bear or starts to try to do activities and says, hey, my ankle's feeling good, but I have this pain up around my knee area that doesn't seem to be getting better. So for this reason, I just adapted over the years that whenever I'm doing any exam, I always start with a joint above and palpate down distally towards the area of tenderness and or the area of concern. So for this patient, again, I started over this proximal fibular area and was able to find the tenderness over this area. I think another key tip is anytime patients have pain, especially increased pain with weight bearing, even in the walking boot, this is always more concerning for me that they have more of a significant soft tissue injury to the ankle area. And I'm always quite concerned about a syndesmotic injury with increased and or weight bearing pain, even in the walking boot or with immobilization. And then the third thing that keyed me in on this patient is medial sided tenderness. So any patient that comes in that has medial deltoid ligament tenderness, that has a injury consistent or concerning for a lateral ankle injury, I'm always concerned that this could be more of an unstable injury, as this deltoid ligament is quite a robust ligament and is not often injured. And so when an injury is associated with this ligament as well, oftentimes it's concerning for an unstable type injury. So if we see a patient that comes in that has, let's say, a distal fibular fracture within the syndesmotic area or distal to the syndesmotic area, and they have this deltoid ligament tenderness, most of us would consider that a functional bimalleolar fracture and a more unstable fracture. These are the patients that we would typically immobilize, whether it be in a splint, walking boot, or cast, and have them be non-weight bearing on this. Whenever I call my foot and ankle surgeons or send them an x-ray of these distal fibular fractures, one of the first things they ask me is, do they have medial sided tenderness? Because again, this is often indicative of the severity of the injury and the instability of the injury. So with these Maisonneuve fractures, the fracture pattern again is quite common. Typically, as by definition of the fracture, they'll have a fracture within the proximal 1/3 of the fibula, either incorporating the shaft or the proximal aspect of the shaft and the fibular neck. And then oftentimes have an injury to the anterior and or posterior tibiofibular ligaments, which can create and or rupture within the area and create instability. Sometimes you will see some medial space widening noted on just the mortise views or AP views, but oftentimes you'll need these stress views to have the widening occur. In these patients that do come in with these acute soft tissue injuries to the ankle, it's hard to get a physical exam that can show you concerns for these syndesmotic injuries, because often this exam is either you have them do the stress view while they're there in the clinic, so you have them lie on the affected side with the fibula down or lateral side down and see if this increases their symptoms because of the widening within the anterior tibiofibular ligament and or posterior tibiofibular ligament and stress to the medial ligament or deltoid ligament area. Or you can dorsiflex them and externally rotate them to see if you can force this syndesmotic area open. But again, when these patients come in and they're acutely injured, these types of physical exam maneuvers are often difficult to do, and you can get false positive examinations while doing these because the patients are so significantly painful. I think this is where further imaging comes in. If there's a concern about possible injury to the syndesmotic area, it's not uncommon to send the patient for an MRI to evaluate to see if there is a syndesmotic injury. And if your facility has the ability to get these MRIs in a fairly timely fashion, they can typically have this done and see one of the specialists soon enough to have these types of injuries fixated with these tightrope fixations and still have a good functional outcome. Regarding treating these patients, when I see somebody in clinic that has a proximal fibular fracture injury, again, this is always and or typically associated with the syndesmotic injury, independent of the deltoid ligament or medial tenderness as well. I'll always keep them non-weight bearing. I'll mobilize them. Oftentimes I'll offer them a splint immobilization versus a walking boot immobilization. I'll have them elevate ice, anti-inflammatories, and then have them follow up in clinic with one of the foot and ankle specialists in 7 to 10 days for repeat evaluation, discussion on continued care. Then they can get these further imaging if necessary at that point. Let's say you see somebody in clinic and they don't have a proximal fibular fracture. They do have a significant soft tissue injury within the ankle and have increased pain with weight bearing, especially with any type of walking boot. I think these are patients that you can definitely keep non-weight bearing and have them follow up in clinic for examination, immobilize the area and allow for the soft tissue injury to decrease or the swelling to decrease within the area. They can see one of the specialists back in that 7 to 10 day window for repeat x-rays, a repeat examination. Possibly at that time, their examination can be more beneficial regarding this concern for syndesmotic injury with these stress view type examinations or functional kind of dorsiflexion, external rotation examinations could be more appropriate and easier for the patient to tolerate at that point. Should the patient walk on this or not? Again, if somebody comes in and they have an ankle injury and they have pain with weight bearing, especially within the walking boot, I'll often have them continue to remain non-weight bearing. What does pain with weight bearing mean? Well, anecdotally, I don't have any literature or evidence to back this up. I think I usually have the patient say a 3 out of 10 on a personal pain scale. So if they're a 3 out of 10 or less while ambulating in the boot, I think it's usually sufficient enough for them to ambulate without concerns for further injury to the area. If they're a 3 out of 10 or more, then I'll typically recommend they use crutches for ambulation assistance, whether it be toe touch weight bearing or full non-weight bearing, until they can get to that less than 3 out of 10 point. And then I'll have them follow up for examination again in 7 to 10 days to allow for that soft tissue rest. One of the big things about ankle injuries is these soft tissue injuries are quite unpredictable. It's hard to give a patient a timeline as far as when they can get better from these, because these soft tissue injuries often have a mind of their own and tend to heal within their own time frame. Sometimes this can be 2 weeks, sometimes this could be 2 months, and I think it's important to educate the patient regarding this, that we're going to give this some time. We're going to allow it to declare itself. We're going to allow the soft tissue to heal, start you with physical therapy and see how things progress. But these can sometimes have quite a prolonged course regarding the recovery, especially if they have any bony bruising or bony edema. Oftentimes they'll have a significant ankle sprain and the soft tissue will start to get better around 6 to 8 weeks. But when they start to progress to ambulatory activities, they'll have continued pain and or recurrence of symptoms. These are often times where they may have some bony edema within that talus secondary to the veracity of the injury. And once they start these weight-bearing activities, that talar bony edema or subchondral edema starts to become flared up. And again, this can require a prolonged course of treatment regarding these ankle injury patients. So I think take-home points when somebody comes in for examination regarding ankle injury, the mechanism injury for me is always a big part as far as how significant the injury was. If it's a basketball player who twisted their ankle while landing on another player's foot and they were able to play the rest of the game but then have increasing symptoms after the game, this is typically a stable ankle injury that can often progress with activities much sooner than somebody that had a fall or an injury and couldn't weight bear immediately afterwards, which is higher concerning for a structural injury. The soft tissue response is a little bit variable, but I do think in general, a large soft tissue response, what I mean by that is a large amount of swelling and ecchymosis around the ankle and or foot area can dictate the severity of the soft tissue injury and possible the prolonged nature or prolonged course of the recovery for this. Pain with weight bearing, especially pain with weight bearing with immobilization, can predict this as well. And then from a physical exam standpoint, definitely endotendinous within this proximal fibular area and or deltoid ligament tenderness is concerning. And I would have a Maisonneuve injury high on the list with both of these being the case. Again, always x-raying a joint above and a joint below and always evaluating a joint above and a joint below will help us to prevent from missing these injuries. Thank you for listening to this case presentation. I hope you enjoyed it. Please feel free to reach out regarding any topics you'd like to see covered in the future.
This is Sam Dyer from the orthoPAC, and I wanted to invite you to some upcoming episodes. When can I return to sports after my injury or orthopedic condition? And looking forward to a discussion on the most recent practice and salary survey. I wish you all a safe and happy holiday season and a prosperous new year.